of diet and exercise in women with cancer. I profusely thank Dr. Shambhu Smedar, Dr. Alok Modi, and all the organizers of this important conference to give me a chance to speak in this web-based conference. To introduce the topic, cancer poses a significant burden globally, particularly among women. Breast cancer is the most common cancer affecting women in India and worldwide, with the increasing incidence and mortality rates. In India, breast cancer is often diagnosed at a younger age and at a much advanced stage compared to Western populations. Cervical cancer is also a major concern in India, with the country accounting for 23% of the cervical cancer related deaths in Asia. The burden of female cancers varies across regions, with substantial heterogeneity observed at state level in India. Globally, cancer incidence and mortality is projected to increase significantly by 2040, with larger proportional increases in low and middle income countries. Now, in this talk, basically, I have mainly focused on the American Society of Clinical Oncology, that is ASCO guidelines, World Cancer Research Fund, and American Institute of Cancer Research guidelines in relation to this talk on diet and exercise in women with cancer. Also, I looked at the Indian guidelines, which are exactly the similar, with some Indian addition to the data basically. And we have ICMR NIN, Tata Memorial. They have contributed, but no formal guideline has come out as a consensus in India. Now, this was a very important survey that National Coalition for Cancer Survivors survey being conducted in the US basically every alternate year. And the cancer survivor defined as the person living with, through, and beyond a cancer diagnosis. Survivors in this survey call for a focus on physical and mental health. The most common side effects they report are fatigue, 46%, fear of recurrence, 42%, pain, 37%, mental health issues such as depression, anxiety, 57%. Priority areas identified in the survey were related to exercise, nutrition, strategies to reduce pain and fatigue. Here, exercise plays a major role. They also highlighted the integrated oncology opportunities with the aid of exercise, dietary supplements, massage, mindfulness, spiritual practices, and relaxation techniques were the most emphasized. Survivors needed information and education. ASCO during treatment guidelines regarding exercise, this is concise, we'll discuss in detail later. Focused on patient on active treatment with curative intent, 53 systemic reviews and 23 RCTs were taken into consideration. They stated that aerobic and resistance training exercise should be the standard of care because exercise reduces toxicity of cancer treatments, improves strength, cardiovascular fitness, and physical function, improves quality of life and mood. And there's an emphasis on aerobic exercise and resistance training should be definitely placed. Regarding the diet, basically, regarding the nutrition and weight management, there is insufficient evidence to recommend any particular type of a diet. Any healthy diet is recommended, but neutropenic diets are not recommended. There is also insufficient evidence to recommend weight loss or prevention of weight gain. However, this does not negate the importance of healthy diet and weight management. However, we need more studies, more long term studies to make a final comment on this. What is known as diet quality and survival. High quality diets, often defined as the existing guidelines, are associated with improved survival in breast and colorectal cancer survivors. In this meta analysis, there was 23% overall mortality benefit for those with highest quality diet. Inflammatory diets are detrimental to the patients with cancers, and therefore, patients with cancer should follow the anti-inflammatory diets. We'll discuss what are the anti-inflammatory diets. Colorectal patients benefit from Mediterranean diets. However, DASH diet basically showed no survival benefits. Other cancers, evidence for cancers like ovarian and bladder cancer is limited at present. Now, coming to the neutropenic diets, it does not reduce infection risk more than safe food handling and hygiene, and therefore many of the centers would prioritize food hygiene and safe food handling or neutropenic diets in patients with immunosuppression. Now, these guidelines pertain to cancer prevention and cancer survivorship, where we have more evidence beyond the cancer survivorship beyond the period of treatment. Here we have more evidence, and here the World Cancer Research Foundation and the American Institute of Cancer Research guidelines and the American Cancer Society guidelines. I have displayed basically the American Cancer Society guidelines are a extrapolation of the World Cancer Research Foundation guidelines. What they say is that you should maintain a healthy weight. In India, they say that 18.18 to 25, you should maintain BMI, eat a diet rich in whole grains, vegetables, fruits, and beans, that is prudent diet. We should limit fast foods, other processed foods high in fat and refined starches and sugars. Red and processed food should be limited to less than 18 ounces per week in men and less than 12 ounces per week in women. Sugary drinks to be avoided basically. So you have to avoid all these processed foods, sugary drinks, which are inflammatory diets. You should also limit alcohol to less than 1 to 2 drinks per day. However, the American Cancer Society totally prohibits, it says that best not to drink alcohol. Physical activity, 150 to 300 minutes of moderate activity per week, or 75 to 150 milligrams of moderate activity, or vigorous activity per week, and resistance training for at least 2 days a week, which are the standard guidelines for any chronic disease. Now, coming to the obesity and the relative risk of cancer, a woman who had cancer is at a much higher risk of developing a second cancer. And you can see all these cancers which are related to obesity, basically, or endometrial cancer tops the list with 7 times more incidence of cancer in obese patients. And you can see a host of cancers which are prevalent in women, which are exacerbated by obesity, and therefore obesity is not a good thing. Coming to the obesity and cancer-related mortality, obesity is a poor prognostic factor for the cancer mortality, which is shown here basically, and you can see the female side of it basically, and you can see very well that all these cancers are having a worse mortality, and the worst mortality is the cervical cancer, kidney cancer, uterus cancer. The prognosis is bad if the person has obesity. Coming to the prognostic effect of weight gain amongst individuals with breast and prostate cancer, we'll talk of breast cancer because it pertains to women. And you can see that there is a 29% excess risk of mortality, 8% excess risk of all-cause mortality in patients who have inappropriately gained weight, who have this breast cancer. Coming to the weight and cancer prognosis, so we have very, very well seen that an increase in weight may increase the risk of cancer, may increase the risk of survival. However, whether a decrease in weight decreases risk is not yet proved. And there are two large-scale trials which are being conducted. That is a breast cancer weight loss BWEL trial and the lifestyle intervention for ovarian cancer enhanced survival, that is LIVES trial, which are ongoing. Basically, a lot of data from LIVES trial has come, but still this finding that weight loss improves cancer survivorship is not definitely proved. Both these studies have not still shown any beneficial effects of weight loss on enhanced cancer survivorship. However, the weight loss definitely confers metabolic benefits, and you know that 3% of weight loss is associated with health benefits. So, a healthy weight loss is recommended in patients of cancer, especially if they are overweight, basically. 2 pounds per week, we should not exceed weight loss beyond 2 pounds. So it should be a gradual weight loss. If the patient is elderly, you can settle for 1 pound per week, basically. The best strategies should be the healthy weight loss with some amount of calorie restriction, increased physical activity, behavioral modification, which the patient should be taught to self-monitor, like weighing daily, keeping a food and exercise log journal, and electronic devices support. And however, there are no recommendation regarding the distribution of micronutrients, so we should not avoid keto diet, this diet, that diet to that patient. How important is the diet quality? For this is the meta of 130 studies, 113 studies, and they've definitely shown that 14% reduction in the incidence of cancer with patients on healthy diet. Cancer survival and with overall mortality also decreases to the tune of 16 to 18% with a good healthy diet, and therefore we cannot emphasize a prudent diet more. Coming to the association of alcohol and cancer, no amount of alcohol is safe. But there are four ways alcohol causes cancer: damages cells, increases damage from tobacco, affects hormones linked to breast cancer, breaks down into cancer-causing chemicals, mouth and upper throat, larynx, esophageal, breast, liver, and bowel cancer exacerbated by alcohol. Therefore, exercise, physical activity, improves the survivorship in our patients of cancer, and there are multifaceted benefits. The cancer-related fatigue improves, health-related quality of life improves, physical function improves, anxiety improves, depression improves, sleep improves, lymphedema improves, and the bone health is improved, and therefore this should be a standard of care basically. We should know what are the other benefits of exercise in preventing cancer. There is a risk reduction in other comorbid conditions like the cardiovascular diseases, diabetes, stroke, benefits for reducing risk of falls, balancing flexibility is improved, assisted daily activities of daily living also decrease, joint pain also decreases, limited disease-specific exercise prescription in cancer does not exist because we do not have proper guidelines. However, more activity appears to will lead to more improvement up to a certain extent. So, new areas of research such as bone metastasis, we should reinforce the patient should strive for regular physical activity and exercise regimen because the benefits of exercise, even with bone metastasis, outweigh the risk basically. Now, exercise during cancer treatment, exercise generally safe during chemotherapy and radiation. Reviews report no increase in adverse effects. Most patients tolerate supervised exercise very well. It should be a supervised exercise. In ovarian cancer, for example, exercise during therapy was feasible and did not worsen treatment. During treatment, moderate exercise, walking, gentle yoga can mitigate treatment side effects, help maintain strength, reduce fatigue, even while undergoing chemoradiation. Some studies show fewer treatment interruptions and less deterioration in function during exercise. Exercise, there is a improved survival, 42% lower overall mortality in this study, basically 40% lower breast cancer related mortality, and the recurrences were reduced by 21% with exercise. In exercise survival recurrence, in this meta-analysis of RCT, it was found that there is a reduced mortality and reduced recurrence. Extended survival is the result basically, and therefore it is very important. Now, the lifestyle practices of cancer survivors were studied on the right side. These are the percentage of patients who are not following these recommended lifestyle modifications. So you can see a very, very good amount of people with cancer are not following the recommended lifestyle modifications. And it was noted in this trial that 77% of the cancer survivors practice one or more bad practices. And therefore, we should emphasize all these healthy practices when the patient comes to you because physician is a powerful influence on health behavior of patients. A patient who has been diagnosed with cancer is very receptive to what the physicians are telling him, and therefore physicians should advise, educate patients. 92% of the patients have prefer to receive guidance from their providers at the cancer center, and the guidance given is very, very important. This is a very, very important teaching moment for a lifestyle change. We should ask which diet the patient prefers. So, individualization diet, we should not enforce any particular diet on the patient. According to the patient preference, we should advise diet, assess whether the patient is able to take that diet properly, assist if there is any issue, and we should arrange for an alternative diet if patient is not able to maintain it. The same goes for weight management. We have to we should follow these 5 A's, and same for exercise. Even exercise has to be individualized. You cannot enforce a patient. Some patient would like to swim, some would like to cycle, some would like to walk. So every patient has a particular preference for exercise, and therefore to implement give the message properly, we should include lifestyle related questions in your intake forms where you know the patient preferences, ask patient details about how they move, general nutritional knowledge and desire, because we should know the baseline and we should improve upon that baseline, provide personalized recommendations versus general guidelines wherever possible. Because if you enforce guidelines, patient not accept it. Patient, it has to be a personalized medicine now. We should, even if you're referring the patient to some other specialty or some other person, you should talk to that person in the patient, presence of the patient so the patient feels that you are concerned from him and he is more receptive to going there and following his advice. Include other members of your allied team or support team in discussion so that it is like a family discussion. How patients facing resources or toolkits. So in the waiting room, you should have all the resources, toolkits, brochures, so the patient can pick them up and read them. Document in patient note for follow-up. To re-engage with the 5S, you should reinforce because if you advise only once, diet or anything, the patient forget after. So reinforcement is a very important medical strategy, and consider community partnerships for gaps, peer groups. We have a lot of resources available on the net, general lifestyle resources, exercise resources, and diet, nutrition, and healthy weight resources which should be taken into account basically, and the relevant website details should be given to the patient. The peer groups should be, patient should be included in the peer groups. So to conclude, basically, the key recommendations are diet advice: promote a balanced plant-rich diet, encourage fruits, vegetables, whole grains, lean protein, discourage processed foods and sugary drinks, physical activity, regular physical activity, at least 150 minutes of moderate physical activity or 75 minutes of vigorous physical activity with at least 2 sessions of rest. Sustaining weight management is very, very important. Maintain optimum weight, basically, not to inappropriately lose weight. Weight loss should be scientific, supervised, and following the scientific principles. And the weight gain also, if the patient has lost, become cachexia to weight gain, should also follow the proper modality. We should follow the safe practices. We should not unnecessarily advise the neutropenic diets, and rather proper advice, proper food hygiene, proper food handling to the patient. Symptom control is very important. If the patient is having, suppose, nausea, you should give antiemetics so that he is able to maintain his diet and exercise. If he has pain or anemia, that should be treated so that he can maintain his diet and exercise. Patient education is also very important, because unless you emphasize, educate the patient, he is not going to follow the recommendations. The research gaps and future directions, larger diverse trials, because well-powered RCTs are needed on specific diets basically, and exercises across cancer types and therapies which are not available for all cancers. Mechanistic study, how explore how diet exercise affects tumor biology, immune response, hormones, and inflammation to guide targeted interventions, personalized interventions, identify subgroups like age, menopause, genetics that benefit most. Well study suggests that low-fat diets aid non-menopausal women. Behavioral change, you have to go for behavioral change, use of apps, motivational interviews to improve adherence, because 90, we have seen that 77% of survivors don't meet their lifestyle goals. Long-term outcomes, most studies are short-term. Future must assess survival, occurrence, and late effects over extended follow-up. Multidisciplinary models assess integrated oncology models with dietitian therapists for effectiveness and cost in survivorship care. So I thank you all for patient listening.